Ok.
Bom dia a
Okay.
todas as pessoas
Good
presentes.
morning,
Hoje
everyone
vamos
attending this
contar um
session. I
pouquinho da
welcome you
história de
all
10 anos da epidemia de Zika no
to
Brasil,
this 10 years of a
contribuições da
Zika epidemic in
plataforma
Brazil,
de vigilância de longo prazo e suas consequências, a
contributions
plataforma Zika.
of the
Eu sou Mariana
long-term
Pinto
surveillance
Lima,
platform for
pesquisadora
Zika and
associada
its
do Centro
consequences. I am
Deepening de
Mariana
Coleção
Lima,
de Dados de conhecimentos
associate
para saúde de
researcher
dados
at
Fiocruz
CIDACS
Bahia.
Fiocruz, Bahia.
Trabalho com Betânia Almeida, na
I
linha de
work
pesquisa
together with
Ciências
Betania
Sociais.
Almeida
E
on
ontem
Science and
nós
Society
acompanhamos, tivemos um
Science and
acompanhamento das
Society study
experiências
line.
com dois
Yesterday, we had already
painéis.
started an
No
exchange of
primeiro, dei um
experiences and
recorte
idea
geral
on two
sobre a
different
epidemia de
panels.
Zika no
On the
Brasil e na
first one, we
Ecamérica
talked
Negra.
about the
E no segundo,
perspectives
conversamos sobre a
addressing the Zika
plataforma
epidemic in
Zika, suas
Brazil and America and
contribuições,
Caribbean. The
a
second
partir de
one
estudos
was
de grande base de dados
about the
vinculados.
originality and importance of Zika
Com
platform in
pesquisadores
longitudinal
e
studies
parceiros
based on integration
colaboradores.
in secondary
Hoje nós
of
iremos
secondary data.
discutir
Today we are
estudos
going to
longitudinais de
talk about
cohort
longitudinal cohort studies
sobre Zika e síndrome congênita
on
da
both
Zika,
Zika and congenital Zika
focando como
syndrome,
esses estudos
focusing on
contribuem
how these
para a produção
studies
de evidências à
contribute
saúde
to the
pública,
production of
como suas
evidence
potencialidades
to
desafios.
public health as well as importance,
E
potential,
agradeço
and
aos
challenges. I
palestrantes,
will start by
Elizabeth,
thanking the
professora
speakers,
Elizabeth
Professor
Brickley, professor
Elizabeth
Ricardo
Brickley,
Zimenez,
Professor
professor
Ricardo
N. Cruz e
Zimenez,
nossa
Professor
moderadora
Annie
de hoje,
Cruz, and our moderator
Elizabeth
today,
Moreira.
Professor
Eu
Elizabeth Moreira.
reforço que esse webinar faz
I
marco no
ratify
10 anos,
that
10 anos
this
da epidemia.
webinar is a
Faz
milestone
parte
of
das
the 10
ações da
years of Zika
plataforma
epidemic, and
Zika,
it's part of the
plataforma de
platform
vigilância
as
de longo prazo
Zika
e suas
activities, a
consequências,
long-term surveillance
que visa
platform for
aprimorar
Zika
o
and its consequence,
conhecimento
aiming at
científico
improving
sobre o espectro
scientific knowledge
clínico
on the
da síndrome
clinical
congênita de Zika e seus
spectrum
impactos
of
sobre as crianças e famílias no
congenital
Brasil,
Zika syndrome and its
apoiar
impact on
ações e
children and
atitudes com
families
medidas de
in order
saúde
to support
pública
measures
adequadas.
and
Trata-se de
appropriate
um
public
trabalho que
health
integra e cruza
activities. It is
dados
a
de
work that
diferentes sistemas de
integrates and crosses
informação
data from
públicos
different national
e sociais de
information
saúde ao longo
systems,
do tempo, a exemplo do Sistema de Informação
such
de Nascimentos
as
Vivos, o
the
SINAS, o
live
Sistema
birth
de Vigilância Alimentar e Nutricional,
system, as
SISVAN, o
well as
Sistema de Informação
nutritional
sobre
system,
mortalidade
SISVAN,
e
mortality
informação sobre
information
cobertura
system,
hospitalares, e o
hospital
Cadastro
admission
Único,
systems, as well as a single
a
registry,
produção, o Cadastro Único de Programas
a
Sociais do
single
Governo Federal.
registry of social
A integração
programs
desses
of this
dados
federal
e
government.
junto
The
longitudinais
integration
permite
of
responder
data
a
in
perguntas
longitudinal
precisas sobre o que
structures allow
aconteceu e pode
us to
acontecer com as crianças que
answer
nasceram entre
research
2015 e
questions on what has
2017
happened to children
e
born in
outros períodos
between
também
15 and
ao longo
17,
desses
as well
10
as other
anos.
periods throughout those 10
E
years.
além
And
de representantes
in
aqui da
addition
plataforma Zika
to the
CIDACS, o
representatives of a
webinário
Plataforma
contará com a
Zika,
participação de
the
parceiros
webinar
como a
will also
Secretaria de
have the
Vigilância em Saúde
participation of
do
partners
Ministério
such
da
as the
Saúde do Estado do
Department of
Brasil,
Surveillance
a
of the
Universidade
Ministry
Federal da Bahia,
of
a
Health, the Federal
Universidade
University
Tropical
of
de
Bahia, the
Medicina, a
London School of
Universidade Federal
Hygiene
de
and Tropical
Pernambuco e a
Medicine, Federal
Fiocruz
University of Pernambuco,
Pernambuco,
Fiocruz Brasília, Fiocruz
representantes da
Pernambuco,
OPA e da Unizika.
representatives of Pan American
Vamos
Health
continuar aqui o
Organization,
diálogo
and
com nossos
Unizika. We're going
painéis,
to
as
keep on
diferentes
listening
representações da
to
sociedade, da
different
saúde coletiva,
representatives
do
of
setor de
society, collective
ciências,
health,
que certamente irão
sciences
contribuir
sectors
para
who
trazer
will
novos
certainly
olhares
contribute to
com as que nos
with
foram
new
ocorridos até aqui, que
prospects and
a gente ainda tem
perspective
que
on what we
pautar e
have done
avançar
so far
nessa
and what
agenda
we
de
are
10
already
anos.
missing in our
Você
research
poderá
agenda.
enviar suas
You
dúvidas
can
ao longo das
forward your
apresentações
questions during
pelo
the actual
chat do
talks
Zoom.
through the
E
chat
após o painel, a
tab,
gente vai ter as
and after
apresentações,
the
após o painel, a
panel
gente vai ter um tempo
we'll have a
de discussão,
Q&A
discussão e
session
perguntas.
with discussions
Lembre que
and
esse
questions
webinar está sendo
answered.
transmitido
I
no canal
remind you that
CIDACS
this
no
webinar is
YouTube,
also being
onde
broadcast
ficará
the
registrado também para quem
YouTube
quiser
CIDACS
rever
channel, and it will be there for whoever wants
compartilhar
to
essa
visit and
informação
watch
com
it
outras
later
pessoas.
after we're done
Ofensas,
today.
comentários preconceituosos e
Offenses,
desrespeitosos
prejudice,
resultarão na
comments, and
remoção da sala.
unrespectful remarks
E a gente
will
vai começar
lead to the
agora com as
removal
apresentações dos
of the
convidados
perpetrator. And
convidadas
we
de
will
hoje.
now start with the
Depois a gente vai
introductions
ter
of
esse espaço
our
para
invited
perguntas,
guests, and then
e
in the end,
agradecer
a
mais uma
Q&A
vez a
session. Once
presença
again, I
dos
thank
nossos
you
convidados
very much,
e também
invited
todas as pessoas
guests
que
and
estão acompanhando.
participants, for joining us
Então
today.
vamos iniciar, né, o
So we
primeiro
will begin
talvez
panel
contingênitas,
number
precoces e
3. Yesterday we
diferenciais.
had two
Com
panels.
esse
Today we're
painel,
going to
que é
start with this
intitulado Estudos de
panel
coorte
called
sobre Zika
Cohort
e Síndrome
Studies on
Congênita do
Zika and
Zika,
Congenital
traduzir
Zika
importância,
Syndrome in Brazil,
potencialidades e
Importance,
desafios,
Potential and Challenges.
composto por três
And we will have
palestrantes e
three
uma
distinguished
moderadora.
speakers
A
and
primeira
one moderator.
palestrante
The
vai ser a
first
professora
speaker
Elizabeth
is
Moreira,
Professor Elizabeth
ex-presidente da
Brickley.
Comissão
She is a
Regional
director at
da
the
Escola de
Global
Saúde
Health
Pública do
Center
Colorado e
of the
professora de
Colorado Public Health
Epidemiologia e
School and
Saúde
professor of
Planetária
epidemiology
na
and
Escola de
planetary health at
desculpa, na London School of Hygiene and Tropical
London School
Medicine,
of Hygiene and
em
Tropical
Londres.
Medicine
Ela
in the
também
UK.
participa,
She
né, atua como
also
co-líder do estudo
performs as
Life-Zika.
co-leader of IV
Depois a gente vai
Zika
ter
study.
a apresentação do
And
professor
then
Ricardo
we'll
Ximenes, que é
also have
professor
the talk
titular
by
da
Professor
Universidade Federal de
Ximenes, full
Pernambuco,
professor at the Federal
professor
University of
permanente da
Pernambuco,
pós-graduação em medicina
permanent professor
tropical e
of
professor associado
postgraduate
da
studies on
Universidade de
tropical
Pernambuco
medicine,
e
associate professor at
co-líder
the University of
do estudo
Pernambuco, and
Life-Zika.
co-leader of the Life
Depois a
Zika
gente vai ter a apresentação da
study. And
professora
then we will
Eni
have
da
the talk
Paixão
by
Cruz,
Professor
que esteve
Eni
conosco
Paixão
ontem
Cruz,
como
who
moderadora
were
do
here with
painel.
us yesterday as a moderator
Professora
in the
associada da
first
London
panel.
School
She's
of
associate
Hygiene and
professor
Tropical
at the
Medicine
London
e
School of
pesquisadora
Hygiene and
associada
Tropical
da
Medicine and associate
Universidade
researcher at
Fiocruz.
CIDACS
E nossa
Cruz.
moderadora de
And
hoje é a
our
professora
moderator
Elizabeth
today
Moreira,
is
que é
Professor
professora
Elizabeth
titular
Moreira. She's a full
do
professor
Instituto Fernando Figueiras, na
at Fernando
Fiocruz, Rio de
Filgueiras
Janeiro,
Institute,
na
Fiocruz, Rio de
pós-graduação em
Janeiro,
saúde da
and
criança e da
graduate
mulher e é
studies
membro
on the
do The
health of
Society
children
for
and
Pediatric
women. She's a
Research
member
e
of
também da
Society for
Sociedade
Pediatric
Brasileira de
Research and also
Pediatria.
of the Brazilian
Eu vou
Society
passar a
on of
palavra para a professora
Pediatrics. I will
Elizabeth
immediately give the floor
Moreira,
to Professor Elizabeth Moreira
que iniciar
for her
o nosso primeiro painel.
initial
Muito
remarks
obrigada.
and
Sejam
introductions. Thank you
todos
very
muito
much,
bem-vindos.
and once
Bem-vindos.
again, welcome. Good morning, everyone, and thank to CIDACS for the invitation. This is a very important year because we started to focus again, particularly now, on children, because the epidemic has somehow ended, but children are still being followed up through a collective effort by the London School, Recife, Life Zika in general. We following up those children. This year specifically, mothers had a great achievement, which was the introduction of lifelong pension, and this is no doubt uh, an important element to them who are already being called warriors, but they no longer want to be warriors, as they say themselves. So it is very good to focus on studies again. Is cohort studies on Zika congenital syndrome, as well as importance and challenges. Of course, that after 10 years, mothers are now dealing with different issues, and every new day is a different problem that emerges. Right now, the most important problem is school. This is what we are working on, in our cohorts, trying to identify problems and somehow uh, raise the awareness on how important they are, and challenges that are we face every day. And it is cohort studies that provide this knowledge to society in general, to science, and to society, and notably to their children and their families. I will now give the floor, first of all, to Dr. Elizabeth Brickley. She will deliver a talk on cohort studies.
Thank you so much, Elizabeth, and thank you to the organizers. Bom dia, good morning, everyone. Thank you, everyone who's joining us online, and I'm truly honored to be here today and to mark the 10 years that have passed since the emergence of the microcephaly epidemic in Brazil. I wanted to start my talk by echoing what Elizabeth Moreira said, of that I wish to recognize and honor the families who are affected by the Zika epidemic. I think for those of us who are in the scientific community, we're mindful that behind every data set and policy, there are real children and real parents and real caregivers whose lives have been profoundly changed. And for all of the caregivers and parents who are here today, we're truly grateful for your partnership and for the time and insights you've shared with us, and for your continuing fight for the rights of children with congenital Zika syndrome. So thank you. For today's talk, I wanted to first reflect and remind the community on why it's important that we continue to study the Zika virus. I then wanted to focus on the importance of our long-term cohort studies, and to close out the talk by talking about some of our priorities for future research. And so, as we know, Zika virus infections during pregnancy may alter fetal development, resulting in congenital anomalies. So, what we've learned from the cohort studies over time is that Zika virus can be transplacentally transmitted with a vertical transmission rate where estimates range between around 26 to 78% of infections during pregnancy being passed through to the developing fetus. And we know that these in utero Zika virus infections are neurotropic and may disrupt fetal brain development. Our research has also shown us that first trimester infections are associated with the highest risks of transmission and disease. And we know that some subset of these children who have the Zika virus infections in utero will develop congenital Zika syndrome, which is a distinct pattern of structural malformations and functional disabilities. Congenital Zika syndrome itself has a spectrum of severities, with microcephaly being a marker of truly profound and severe disease that will have life-lasting impacts on the health of the children. And so I think first and foremost, the importance of studying Zika is to remember this, that the impact that we're looking at here is on children who will develop over their lives and need to have additional accommodations as we think about how we can integrate them into our society, and especially now that they're approaching school age, what those new and emerging challenges are that they face. It's also important to remember that the threat of Zika virus has not gone away. So if we look back over the last 10 years, we know that Zika virus can cause explosive outbreaks. We estimate in epidemiology that the basic reproduction number of Zika may range between 3 to 5, which is on the higher end of our infectious diseases. And we also know that it continues to circulate. So here we can look at some data that was compiled by PAHO, the Pan American Health Organization, on the reported cases of Zika virus diseases in the region of the Americas beginning in 2015. And we can see that since its initial detection in the Americas, we've now seen approximately 1 million cases of Zika that have been reported. And so we can see that explosive epidemic that occurred in 2016, but we continue to see the low level persistence over time with seasonal epidemics. I think it's really important that we also take a moment to look at the data from Brazil. And so these are the cases that have been reported to PAHO. And what we can see is that not only did we have that large-scale epidemic in 2016, we also see that thousands of cases of Zika virus disease continue to be reported in Brazil each year. And so the threat hasn't gone away. And so here, if we look at the bottom of the table here, the data from September 20th, just last week, we can see that we have already this year had over 20,000 cases. What's really striking to me, though, in looking at these data, is that if we look at the last 3 years at the cumulative incidence of cases per 100,000 in the population, we can see that we've had a higher cumulative incidence of Zika virus disease in the last 3 years than we did in 2017, which many of us often consider to be part of the original epidemic. And so I think it's really important that we bear in mind that this threat from Zika has not gone away, and that we continue to have children who may be born with congenital Zika syndrome each year. Another important thing to think about when looking at these data is that these may in many ways be an underestimate. We know from our studies of population that approximately 80% of Zika virus infections may be asymptomatic. And among the 20% of adults who will present with symptoms, the symptoms will often be mild and may overlap with some of our other arbovirus infections. And so if we look here at some of the data from the microcephaly epidemic research group cohort on pregnant women with rash, we can see that the most common signs and symptoms are things like fever, joint pain, headache, and muscle pain. And we can see that these are very similar in their presentation and the prevalence of these signs and symptoms to what we see on the left here in the women with Zika virus compared to the women with chikungunya virus. And so it can often be difficult to clinically distinguish between our cases from different arbovirus causes. So another reason why Zika virus is important is really that the risk of a reemergence is worldwide. And so looking at this map of the world, we can see in the dark blue the countries and territories where we have had confirmed Zika virus transmission. And so that is in more than 80 countries and territories to date. But I think the real threat is much bigger than that. And we know that we have competent mosquito vectors in more than 140 countries worldwide. And so this just really emphasizes that it's so important for us to learn from the experience in Brazil and be ready and prepared for an epidemic that can emerge anywhere. And then finally, I think the last piece for me that we need to continue to emphasize is that we need to continue advocating for Zika and Zika research, because we currently have no licensed Zika vaccines. And we also have no licensed therapeutics to treat Zika virus infections or reduce the transmission and the vertical transmission over time. And so there was a number of really promising preclinical Zika vaccines in development, and those are continuing to progress, but we continue to face challenges as we move towards the later stages of our phase 2 to 3 trials and thinking towards potential licensure down the road. Okay, so now I'm going to shift gears to talk about cohort studies. And I think what I wanted to start by saying is that I am kind of the biggest advocate for cohort studies. I think they're incredibly important. But I also wanted to take a moment to acknowledge everything that we've learned through our complementary study designs. And so first, I wanted to recognize that our case control studies were really essential at the beginning of the microcephaly epidemic for establishing Zika virus as the cause of the microcephaly epidemic, and equally as important, excluding alternative hypotheses. And so being able to rule out that things like pesticide exposure were behind the cases of a microcephaly. It's also important to say that case series studies in which we look at several children with congenital Zika syndrome were critical for providing our initial clinical descriptions of congenital Zika syndrome in neonates, and also giving our first case definitions that could be used for public health surveillance. And in particular, identifying children with congenital Zika syndrome when we didn't know whether or not they had been exposed during pregnancy, but we knew that they were born in places that had active transmission during the time of pregnancy. Another key contribution to the field was made by our colleagues who work in diagnostic research, who identified markers for Zika virus exposure. And this is really important when we think about how we may screen populations and to identify those cases. And then a final contribution that I think is important to acknowledge is all of our partners in social science research who did the work of spending time with the families to describe the profound social, emotional, and economic impacts of the Zika epidemic on parents and caregivers. And so to complement that, I think cohort studies with the long longitudinal follow-up over time are really essential in that they allow us to understand the health impacts of prenatal Zika virus exposure on the lives of children and their families. So they have two main functions in my mind. And so the first is that they advance our understanding of risk, both in absolute and relative terms. Cohort studies are essential for us to be able to understand that if someone comes in who has been exposed to Zika virus during pregnancy, we want to be able to tell them what is the risk that their child will develop a clinical manifestation of congenital Zika syndrome. This is important for counseling and supporting affected families and for planning for the future. The second thing that's really important about this long-term longitudinal follow-up is that it allows us to have insight into the evolution and natural history of disease. And we want to be able to understand that when a child is born with different features of congenital Zika syndrome, so if a child has microcephaly, or if they have mild features, or if they are born apparently asymptomatic, what can we expect for their future and what supports might they need to develop and thrive? And so one thing that's been really striking about this long-term research is it has revealed to us that there are some manifestations that may present later in childhood that are not apparent at the time of birth. For example, we've seen that there are cases of postnatal microcephaly, or there are cases where children develop endocrinological dysfunction at later times in their life. I also wanted to note that within cohort designs, it's really important that we have complementary cohort designs. And so I'm so honored to be here today with our colleagues from the Zika platform who work on our electronic cohorts based on secondary data, as well as our colleagues, Professor Elizabeth Murrah and Professor Ricardo Ximenez, who lead clinical cohorts that collect new data. And so our clinical cohorts that prospectively collect this new data during intensive follow-up with the family have three particular strengths in my mind. First, they allow in-depth investigations of specific sequelae. For example, looking at a particular clinical feature in great depth, like something like cryptorchidism in boys who have microcephaly. Another example is with the longitudinal tracking. So we're able to not only know the burden of a disease, but we're also able to follow up and understand, for example, among the children who develop seizures,
Elizabeth, você pode continuar, porque eu acho que a gente teve uma queda da Elizabeth Brickley.
Elizabeth, we lost you. Yeah, she's offline, I believe. I think she's offline. She's not hearing us. If anyone can contact, can get in touch. Yeah, she left now. Yeah, if you can text her, maybe. Yeah, she's out.
Eu tenho aqui o WhatsApp dela.
I've got her WhatsApp number, so I will try to text her. Yes, text her, please. I hope it was not Trump who blocked her.
Falando nessas coisas muito subversivas, né? Então.
Pior que é, né? Não é, Maurício? Vou te falar, viu? Assim, intervenção. Fiquei pasma com a intervenção no FDA também, né? Aí fica difícil. No CDC, no FDA, fica muito difícil para a ciência de uma forma geral.
Ela voltou aqui. Ela voltou, tá voltando.
Yeah, she's back. She's back.
Oi, Lizzie.
Hello, Liz.
Sorry for that. I had a power cut on my side, but I think I'm reconnected. Let me reshare my screen. I apologize.
You have also our solidarity.
Okay, so back to talking about why the like the Zika platform on CIDACS is so important. Is where I think I got cut off, but I think our electronic cohorts allow us to work on these large population data sets, which is really just incredible. And so the first advantage is that they're more representative in terms of being able to capture the full populations. And this large sample size also allows us to study rare outcomes, for example, looking at mortality. And using these large data, we can also do important subgroup analyses, asking very important questions around social disparities and how social factors may modify risks of different outcomes. A final advantage of working with the Zika platform is they also allow us to overcome some of the losses to follow up and the challenges that we face with our clinical cohorts, where it can be difficult to keep children within the studies, particularly those that may not have been exposed during pregnancy. And so there's no need for the annual visits. And so in my mind, these two different approaches to cohort studies are truly great partners. And we can learn a lot by working together in this work. And so I just wanted to share some pictures of what it looks like, and really to emphasize that the clinical cohort studies led by Professor Marrero and Ximenez are truly team science projects where there are these multidisciplinary specialists that come together to evaluate the children over time. I also wanted to say that something that's been really remarkable to me about the last 10 years, in I think the Zika community, more than almost any infectious disease community I've ever interacted with, is at the forefront, is around data sharing and collaboration. And I know Professor Ximenez will be speaking more about the Zika Brazilian Cohorts Consortium, but I just wanted to reiterate the power that comes from the different clinical cohorts coming together and sharing data and conducting joint analyses to learn more about congenital Zika syndrome. I also wanted to highlight the power of the CIDACS Zika Platform. And so this is a study that was led by Professor Paixão, who will be speaking later. But it was important because in an individual clinical cohort, you're not able to easily ascertain what mortality risks and patterns may be over time. But this is the power from when we can use the data linkage and to have this long-term follow-up. All right, and so for the last little bit, I'm going to talk about our ongoing study, which is the Life Zika study. And this is the long-term impacts for families affected by the epidemic of Zika study, which really brings together our multidisciplinary partners to understand in the long term what happens to children who were exposed during pregnancy and their families. And so with this project, we're working both in Rio and Recife, together with some partners from the Zika Brazilian Cohorts Consortium, and also with our partners in Salvador at CIDACS. And within our team, we have clinicians and social scientists and epidemiologists. And our goal is really, first of all, to understand what is the cost of a Zika epidemic for affected families. We want to understand that clinical description of congenital Zika syndrome for school-age children, and to get the first available risk estimates for late-onset clinical and neurodevelopmental manifestations, especially for those children who were born apparently asymptomatic for congenital Zika syndrome. We want to have an improved understanding of the support services required to address health and learning needs of school-age children with Zika-related disabilities and to promote the well-being of their families. And we want to have an improved understanding of how congenital Zika syndrome impacts not only a child's life, but also their mother's. And so what are the socioeconomic impacts for the family? Finally, we hope that this study also gives us methodological and clinical insights on how we can prepare for future epidemics. We want to have an improved understanding of the technical and social challenges related to research, dissemination, and sharing activities during and after a public health emergency. And we also want to work together and bring the Zika community, the research community together to think about dissemination materials, policy briefs, and SOPs, so standard operating procedures for clinicians. So that way we're prepared if there is a reemergence of Zika in the future. I think cohort studies have, as well as many advantages, also have challenges associated with them. So one of the biggest challenges that we face is that long-term follow-up of cohorts is expensive and difficult to fund. And so we've seen kind of a shrinking of the follow-up that's happened around the world. And so to my knowledge today, there are 2 cohorts that continue to be continuously followed up within the Life Zika study. But there's ongoing work to find funding for the many other excellent cohorts that exist. And so I would say that this is an opportunity to think about additional funding for the follow-up of the other cohorts in the Zika Brazilian Cohorts Consortium, as well as the more than 50 cohorts globally that have joined together in the WHO-led Zika virus individual participant data meta-analysis. And I think it's really important that we have this diversity of cohorts so that way we can better understand what factors might improve the prognosis of children born with congenital Zika syndrome and understand how the disease varies across geographies. Another big challenge is that long-term cohort studies require major commitments from the participating families. And it's really important, I think, that this is also seen as an opportunity. And so we are so grateful for the families that continue to participate in this research. And we think that by building lasting relationships with participating families, we can conduct more scientifically sound, ethical, and relevant research. We know that the families have expertise derived from their lived experiences of caregiving. And we think this is really essential for highlighting new research questions, just driving discovery and creating impact. We also see potential opportunities in the future for this closer working of both the clinical cohorts as well as the electronic and secondary data cohorts. And so if there's a possibility in the future of linking our primary and secondary data sources, this may give us an opportunity to overcome some of the loss to follow-up challenges and to understand the impacts of prenatal Zika virus exposure over the children's full life courses and into adulthood. And a third challenge with many of our Zika cohorts is that background risks are poorly understood. And so most of the literature that's been published on congenital Zika syndrome to date has reported on absolute risks. And we know that that can be really challenging, particularly in the different settings where we're working. And so I think there's also an opportunity, and I'm really grateful for the partnership of, for example, the NIH SIP studies who are partnering together to allow us to also identify children who were not exposed to Zika virus during pregnancy, so we can understand those background risks and get more realistic risk estimates moving forward. So I'm going to just close with thinking about some of our key priorities for future research that I see. And the first thing to say is that I think with these long-term research studies, we must continually reflect on how we do our research and try to improve the ways in which we conduct research. So we should always be learning and growing and striving to do our best in this work. And the first thing that is an area that we can continue to grow in, and I'm really inspired by the work of some of our early career researchers and the team who are driving this work forward, is to think about how we can continue to strengthen our partnerships with affected communities. How, as the children are now growing and developing, can we take time to listen and learn from the children with congenital Zika syndrome themselves, as well as their caregivers and their teachers? How can we create opportunities to partner throughout the research project and not just to disseminate research findings to groups, but really think about how we can include them throughout that process? The second area is that I think we can continue to foster a culture of collaboration in team science. And I'm continually inspired by the outstanding model of the Zika Brazilian Cohorts Consortium, which I think in my mind is the gold standard in epidemic response about how different research teams can come together to advance science. I think it's really important that we continue to talk about how we develop harmonized protocols and facilitate ethical data sharing whenever public health emergencies arise. And a third area that I've been thinking about a lot lately is around supporting international cooperation. So I'm based in the United States right now, where it feels like walls are coming up, and there's a moment that we're in where we're kind of shutting down some of these ideas of international cooperation. But I think that's the wrong approach, and I hope that we can share the learnings from the past epidemics to new settings. So when Zika reemerges in a new country, it's really important that we think about how we can transfer knowledge we have gained over the last decade across these borders. So in terms of priorities for scientific research topics, in my mind, there are kind of 4 ones that I wanted to highlight. The first is that I think it's important that we prioritize extending the follow-up of our prospective cohort studies. And so our current study, the Life Zika study, will enable follow-up until the children are around 12 years of age. But it's important that we continue to understand what are the impacts during adolescence and adulthood. Congenital Zika syndrome is a new disease, and we need to understand what those late onset manifestations may be and what factors may promote either different courses of evolution of the disease. We want to know, do apparently asymptomatic individuals experience any sequelae from their prenatal exposure? A second area for future research is on intervention and impact evaluation studies. And here I think it's really important that we evaluate how different health interventions and social policies for children with congenital Zika syndrome and their families impact their lives. So for example, are there educational interventions or social protection policies or support groups that will allow the children to attain their optimal standard of health and well-being? A third area for future research is that I think we need to think more and work more on developing field-ready, low-cost, and specific diagnostic tools. We need to think about things like integrated surveillance platforms and screening strategies. So how can we rapidly identify the emergence of a new Zika epidemic and improve testing during pregnancy? And then the fourth one, I'll say again, I said it at the beginning, but I think it's so important, is that we need to continue to emphasize research on vaccines and antivirals and monoclonal antibodies. Future research should support the development of licensed vaccines and antivirals, explore the unique ethical challenges of this research, and develop public health strategies for their use. It's important that we think about how we can prevent infections in pregnancy and reduce the vertical transmission rates. It's important that we think about how we can license a Zika vaccine in the absence or the low circulation of circulating virus. For example, phase 3 trials may be a major hurdle, and I know there's some ongoing work on human challenge models of Zika virus infection that need further exploration. It's also important that we continue to talk about how pregnant persons may be safely included in our clinical trials for therapeutics and what the target population will be for a Zika vaccine. And so with that, I'll wrap up, but I just really wanted to acknowledge Life Zika's interdisciplinary team and partners. We're so grateful as well for the families who participate in the MERG and the Zika IFF pediatric cohorts, to the partners from the Zika Brazilian Cohorts Consortium, to our partners at CIDACS, as well as at IFF Via Cruz, London School of Hygiene, Tropical Medicine, and the Microcephaly Epidemic Research Group. Thank you, everyone.
Muito obrigada, Elizabeth. Você traz os desafios importantes.
Thank you, Elizabeth. You mentioned very important challenges to advanced research. It is a new disease. We still have a lot to research and understand this disease. I will immediately give the floor to Dr. Ricardo Jimenez for his talk.
Estou partilhando? Estão conseguindo ver a tela?
Sim, Ricardo, estamos sim.
Can you see my screen? Yes, we can.
Ok, então eu gostaria de começar agradecendo.
I would like to start by thanking the invitation to take part in this seminar and reinforce the importance of this kind of event. As it has already been mentioned, virus is still circulating. We do not completely ignore the possibility of a new epidemic, and if the epidemic is gone, children are still here. So it is important to keep on generating knowledge that will subsidize the care required by those children in their families. So, starting here, the discussion of potentials and challenges, I will start with the challenges. And some challenges not specifically related to cohort studies, but these are challenges to all epidemiological studies that are related to Zika virus infections. The very first challenge that we still observe is the constraint of exposure and case definition in epidemiological studies. These limitations may drive a selection bias, may also drive misclassification of exposure and outcome. They are also fostered by unknown spectra of manifestations. They interfere in the definition of instruments that will be applied, and they also impose challenges in comparing different studies and in conducting a pooled data analysis. So all these issues, all these bullets and elements may lead to bias in the estimate of absolute risk and relative risk, and may also be the source of heterogeneity at the individual level or study level. So the way Zika researchers found to cope with these issues were by using different categories of exposure, exploration of different outcomes, and sensitivity analysis. So getting the example of definition of exposure, the decision was to work with all existing assays or assays whose accuracies were known for Zika diagnosis, and by combining those assays, establishing different hierarchy and evidence level. So with different levels of hierarchy and evidence, that from a more robust evidence to a more limited evidence. Those would be the outcomes suggesting infection by flavivirus, but not necessarily Zika virus. So different levels of evidence will allow us to properly work all data available, but they also allow for sensitivity analysis, considering different levels and checking the consistency of results in different categories. The way of dealing with the definition of outcomes was important. So we started working with a myriad of definitions and myriad of outcomes. So the outcomes on the left were realized very early in the epidemic. And then they ended up being included in the definition of the congenital Zika syndrome. But I'd like to remind you that, in fact, microcephaly was just the tip of the iceberg. Those elements on the left were clear at birth, but there is a series of elements listed on the right hand side that are late manifestations or likely possible manifestations of congenital Zika syndrome. All these must be investigated and are being investigated, and consequently, they must be included in the definition of a congenital Zika syndrome. And so I would like to call your attention to the fact that the definition of a congenital Zika syndrome is a definition that is still in progress of development. I mean, all papers and studies are contributing to a final definition. And more specifically related to challenges in Zika cohorts or Zika cohort studies, we know that cohort studies are complex studies requiring an important operational structure, and it will lead to also finance requirements, larger funds. This operational complexity and this larger financial requirement will determine the number of individuals participating in each study. It will also determine the frequency of comparison. So we use external comparison groups, for instance, and in these settings they are more attractive, but on the other hand, they are more likely to the appearance of selection bias and information bias. It will also determine the selection of diagnostic tests, also different follow-up regarding length, frequency, and the different devices to be used. And they also turn attractive the development of a study carried out with special groups, such as high-risk pregnant women. On one hand, it's operational easy, more operationally easier, but there are other challenges, and a common problem to all cohorts is loss to follow up, and in pregnant women cohort, for those outcomes observed that both of these follow-up time is longer, shorter or longer, but for long-term outcomes, this is also a concern. So, the way researchers found to cope with all these challenges was, to work with the different alternatives of cohort studies. Mostly they were local cohorts because it would be easier to set up structure and demand fewer financial resources. And those cohorts were carried out with or without a comparison group, estimating absolute groups or estimating relative or assigned risks. And children's cohorts were also set up and they've been followed up, and these children's cohorts are helping us build the natural history of congenital Zika syndrome. Local cohorts have the great advantages of allowing a deep analysis and explore diversity deeply. Diversity of a congenital Zika syndrome diversity. And on the other hand, there's a disadvantage of not being so accurate and not so comprehensive. And for these reasons, local cohort studies and their results were clustered for a meta-analysis of individual data through consortia, and I will more specifically talk about the Brazilian consortium and the World Health Organization consortium. Another alternative used by researchers were the multicentric studies, who also have constraints and disadvantages that I will mention later on, and surveillance database studies, which I will not focus right now because the CIDACS group would certainly be speaking to it more deeply. I will only mention examples of studies that were carried out, showing the validity, results, and methodological challenges that were faced, and strategies applied to overcome those methodological difficulties. The very first study I'm bringing as example was a study that had the goal of calculating the relative risk and the attributable risk of adverse outcomes uh, uh, from the Zika virus infection during pregnancy. So, in fact, when I mention about calculating attributable and relative risk, we understand that this is a study that has an external comparison group. So, those we had two cohorts. The cohorts exposed was the MERG, pregnant women with rash and who had laboratory evidence of a Zika infection during pregnancy, and the control, the comparison cohort was a ZIP study, and of the ZIP study cohort, the group used for comparison were those pregnant women who were recruited and monthly tested throughout the pregnancy and had their tests negative throughout their pregnancy. So this is the best possible, best group for comparison, since those women were tested repeatedly throughout their pregnancy follow-up. So here I bring some results of this group comparison. So first, regarding microcephaly, we observed that the microcephaly risk in children born from exposed pregnant women is 4 times higher than those children born from women non-exposed women. We have a 72 percent positive and suspect. With this, we're saying that 72% of microcephaly cases among children being born from exposed women could be attributable to this infection. An important information that we see on this particular slide is that we carried out a sensitivity analysis using different cutoffs in order to define microcephaly. So cutoff 2 standard deviations, 2.5, and 3 standard deviations. We can tell that as you increase the cutoff, you increase, therefore, the specificity in defining microcephaly. We also observe an increase in relative risk. Still regarding this cohort, this external comparison group, and specifically focusing on neurological alterations, we observe a neurological alteration risk 7 times more for children being born from exposed women, with attributable risk of 80%, and a risk of image alterations of the central nervous system 12 times higher in children born from exposed women, with a risk of 95% and a risk of displaying at least one manifestation compatible with the congenital syndrome 60 times higher, or 58 times higher, with attributable risk of, say, 60%. Sorry. So, work with a external comparison group imposed some challenges regarding the validity of the studies, but these were solutions found to cope with those challenges. So different characteristics between both cohorts were worked out through the control in the analysis, and variables were controlled during the analysis. There's another concern and another advantage. It increases the internal validity of a study. That's because both cohorts were done in the same place and by the same research group. The other bullet is that the use of several diagnostic tests increased the sensitivity for identifying exposed individuals or exposed pregnant, as well as repeating tests throughout the pregnancy increases specificity for identifying truly exposed or truly negative individuals. Another important was that field workers were not aware of whether they were assessing children from exposed women or non-exposed women. And regarding the periods of data collection, although there was no comprehensive overlapping in both cohorts, there was a partial overlapping, and the data collection data that we're showing right now, it took place between 2015 and 2018, which is not a long period of time. So, stepping towards a different example, I mentioned the prior study as an example of a study with external comparison group and calculating relative and attributable risk. So we now talk about a different strategy that was adopted by Zika researchers, which was the setup of a consortia for jointly analysis of results from local studies. So here, the ZBC consortium of the Brazilian cohorts of pregnant women gathered 13 different cohorts and allowed us to calculate the absolute risk for several outcomes. So there's a great advantage, consortia, which is a possibility of gathering large number of participants. You see that in the Brazilian consortium, we had more than 1,500 pregnant women, all of them PCR positive. I mean, the gold standard molecular test during pregnancy was applied to these more than 1,500 pregnant women, and they were from all Brazilian regions, actually, wherever the the Zika epidemic was observed. So now focusing on absolute risk observed in the consortium study, we observed a risk for microcephaly, a first assessment of about 2.5%, increasing to 4% when we considered any time during follow-up. And the risk of alterations or abnormalities to the central nervous system, specifically ventriculomegaly and calcification, was about twice as high, around 8%. The risk of neurological alterations was at about 18%, 4 times higher than microcephaly risk, and the risk of eye alterations, ophthalmological outcomes, was about 8%. The risk of those children born from infected mothers presenting at least one alteration compatible with congenital Zika syndrome was about 25% when we consider the first assessment, and going to 30% when we considered any time of a follow-up. This slide also brings very relevant information. First, regarding the association between the time of the infection during pregnancy and the risk of a microcephaly, and also the risk of central nervous system image alterations. So the risk was higher in children when the mother infection took part in the first quarter of pregnancy. Another important information is the absence of association between microcephaly and the level the ethnicity of the mother, the color of the skin, and the region where the mothers lived. This finding was extremely relevant because it shows homogeneity of risk regardless of these factors. One topic that was initially raised by the researchers, the hypothesis that there would be higher risk than in Brazil's northeast. The features of the northeast would foster the risk of microcephaly in infected mothers. So the Brazilian consortium data doesn't prove that hypothesis, because once infected, the risk of microcephaly will be the same regardless of where it happened, ethnicity, or social and economic settings. Now, shifting gears to a different example. So we were working with the pregnant cohorts. Now we have the children cohort, and these are helping to build the natural history of congenital Zika syndrome. So MERG is monitoring cohorts of different children's groups: children with microcephaly, children without microcephaly but born from infected mothers with or without symptoms, and also children born from ZIP studying mothers who were tested negative throughout pregnancy. So they are being followed up as comparison group. This is a cohort of children born from non-exposed mothers. This is an example of how this children's cohort is contributing to the understanding of the natural Zika history, or the natural history of Zika. This slide shows assessments that were carried out. These are successive transversal cohorts getting different ages in the lives of those children. What calls our attention is the severity of microcephaly already in the first year of life, and also the increase of complications as time goes by, as those children age. So, between 3 to 4 years, 60% of children with a microcephaly had seizures. The hospital admission frequency in the first year of life, about 20% of children, going up to 70% the age of 3 to 4 years. And the follow-up of those children in the children's cohort is helping build the natural history of congenital Zika syndrome. Not only children with microcephaly, but also children without microcephaly, either symptomatic or asymptomatic at birth. This is just an example, another example. Here we have results regarding dysphagia. We could tell that children with microcephaly, the risk of dysphagia was about 30%, while in children born without microcephaly but from exposed mothers, the risk of dysphagia was at around 8%. So, in fact, the children's cohort is allowing us to improve our knowledge on possible manifestations of congenital Zika syndrome, and work in all these spectrum of manifestations to so that we can get to a final definition of congenital Zika syndrome. Now, mentioning another example, which I had briefly mentioned before when I talked about the Brazilian consortium. Now this is the World Health Organization consortium, and it calls our attention to some other aspects and challenges that are imposed when we work in consortia. So the World Health Organization consortium, it includes 54 studies. Of these 54 studies, 25 were used in the analysis in the first phase. I'm talking about 27 studies, but those 27 studies represented data from nearly 10,000 pregnant women and approximately 10,000 children. So, comparing the Brazilian consortium to the consortium of the World Health Organization, they are actually a complementary consortia. The Brazilian consortium work with a smaller sample size compared to the WHO consortium, but it has the advantage of being more homogeneous. While the WHO consortium, the sample size was much larger, but with the challenge of dealing with its heterogeneity at the time of analysis. So, these sources of heterogeneity must be considered, and that's why they decided to take different analytical approaches and different assessment approaches, considering the heterogeneity as a way to solve the issues that were imposed. So results. Here we see results for microcephaly. We had individual data and meta-analysis considering one stage, two stages, considering a Zika virus infection definition given by this study itself and another standardized definition that was shown by the Brazilian consortium earlier on, that was also adopted by the World Health Organization consortium, but also applying a Bayesian analysis and a frequency analysis. Of course, the results will vary a little bit depending on the specific approach, but there's certain consistency in results obtained from different approaches with analysis of with results of meta-analysis done in the smaller groups and the results that were published in the literature for more localized studies. And finally, another alternative applied by researchers in Zika was the development of multicentric studies. So multicentric studies have a great advantage. They use a very strict methodology that is applied to all findings. And these are the same instruments and the same techniques applied to all individuals everywhere where the study is carried out. So it allows us to work with a very large sample size. So the ZIP study, for instance, gathered about 2,500 pregnant women and worked at different sites, both in Brazil as well as in other American countries. So all this challenge, all this methodological strictness and infrastructure that is required to develop multicentric studies also bring a problem, which is the time it takes to begin data collection. So, a ZIP study for instance, faced an important challenge. When it started the data collection, the epidemic was already decreasing. So some of the results found did not have enough power to prove a statistically significant difference. So though different outcomes were observed, but a low frequency of infection in pregnant women and the fact that the outcomes were relatively rare didn't allow this difference to become statistically significant. So, what are the prospects? What are the challenges that we would be facing from now on regarding cohort studies? So, the first possibility has already been mentioned by Elizabeth Brickley, which is the possibility of following up children with long-term outcomes, and this is being done by Life Zika. Life Zika is working with primary data, but also secondary data, but also working or organizing itself for analysis, and afterwards that will be a linkage to the database and doing an analysis that can cluster based on secondary and primary data. So in terms of possibility, with the further analysis of the Brazilian consortium will still be done. It will characterize 843 children with Zika-related microcephaly. It will also be possible to conduct a further analysis using all data sets of the WHO, but now incorporating all databases that were not used in the first stage. And the large sample size to be obtained will certainly allow us to work this data collectively, but also break down these data into more homogeneous subgroups and carry out analysis in subgroups. Another very important and interesting thing will be the use of these multicentric analysis of children non-exposed and born from non-exposed mother. But these studies, given the standardization of instruments, standardization of data collection and all, is definitely the best comparison group to all other consortia. And we still have methodological discussions on alternatives of analysis to deal with the complexity of heterogeneity of data, especially when we work with the data from multiple sources. But at last, I'd like to end inviting you all to take part in the next Zika meeting that will be held on the 20th and 21st of October here in Recife. Thank you very much. Thank you, Ricardo. You mentioned quite clearly the challenges, to develop and follow up cohorts, keeping in mind that the children's cohorts impose an additional challenge. It's because as children age, the developmental stages also change. So different essays or different tests must be applied to different contexts and settings. This is important. I will now give the floor to Annie Cruz for her talk on surveillance. Thank you, Elizabeth. Ricardo, I need you to stop sharing so that I can. Thank you.
Então, obrigada, Elizabeth. Eu queria agradecer também.
Thank you, Elizabeth. I'd like to thank the organizers for the kind invitation. And today's talk was quite timely. Elizabeth offered an overview on cohort studies for the specific topic of Zika. And then Professor Ricardo talked about primary data cohorts with more clinical data. And now I'm going to specifically talk about cohorts using secondary or administrative data collected by the Ministry of Health and other ministries as well for the congenital Zika syndrome study in Brazil. I will start with something that has already been mentioned, which is a natural history of congenital Zika syndrome, which is under development, as Professor Ricardo said. We know some of the characteristics. We know that these children display a spectrum of abnormalities, from congenital atrophy to microcephaly, most studied one, by the way, some issues related to dysphagia. Now, it is also clear to us epilepsy that is also well described in these children, but we also must understand a little bit, that with all, in face of all these conditions and sequels and syndrome, what are the children's prognosis with congenital Zika syndrome? And for us to understand it a little bit, we had the goal of researching the mortality among those children as well as hospitalizations. Uh, the rate of hospital admission to hospitals. Their rate of hospital admissions. And like Professor Ricardo said, this is very difficult in primary cohorts because we have a small sample size. Although alarming, it is a rare outcome. That's why we need administrative data and large databases so that we can actually check those outcomes that are still somewhat rare in our population. And for us to understand the prognosis for those children with the congenital Zika syndrome, we use the database produced by the Ministry of Health, such as Life Birth System, SINASC, SIM, RESP, hospitalization data, as well as the single register in some of our assessments. We, of course, had some exclusions in these studies. We may talk in detail about it later on. The studies are actually published, so I will go straight to the results. But for us to do it, we know that these databases are all separated, so we needed to gather all these databases. So first of all, we had a data linkage process so that we could actually gather all the information required. This paper was published by our team of a Zika platform, CIDACS Zika Platform. It shows mortality in children with the congenital Zika syndrome compared to children without congenital abnormalities. And we can tell, I'm not sure you actually can identify the color, but there's somewhat more, this pinkish color represents mortality. And the hazard ratio of overall mortality in under 5-year-old children comparing children with a congenital Zika syndrome to children without congenital Zika syndrome. And then we can tell that mortality is much higher here, 11 times higher. And when we broke it down by specific causes, including neurological causes or infectious causes, we see that this mortality rate is even higher, particularly when we talk about neurological related causes. This hazard ratio gets to more than 100 times higher in Zika, in the congenital Zika syndrome compared to control children. And Professor Ricardo showed how they are detected when the studies recruit children in primary data. And we also wanted to understand the hospital admissions, how it was. I mean, we realized that children without congenital Zika syndrome, represented in a blue bar, more than 80% of those have never experienced a hospital admission. But when we compare these to children with a congenital Zika syndrome, we realize that only 33% of those were in our database that had never been hospitalized whatsoever. But then 26% had at least one hospitalization compared to 13 in the comparison group. And then the same thing, always the red bar represented children with the congenital Zika syndrome, and of course, and always we have the red bar higher than the blue bar, which represented the children without congenital Zika syndrome. We wanted to understand how those hospital admissions took place according to the age groups of children. When we have databases with large numbers, we can also do this kind of stratification to understand what happens in prenatal period, post-prenatal, after 1, 2, from 2 to 4 years, without facing some problems that are imposed by traditional cohorts, such as follow-up loss, which was mentioned here a couple of times. So we can actually follow up these patients without the risk of having them withdrawing the research, because we do this follow-up by data linkage. And then I've highlighted some figures. It's related to risk. This is absolute risk of hospital admission in the first 27 days of life. Without a syndrome, the risk is 163 per 100 individuals. But those children with the congenital syndrome, it goes up to 576. In the prenatal period, as expected for any children, this absolute risk is much higher. But when we check the risk, and then it goes down as age increases in both groups. But when we go to relative risk, those children with and without congenital Zika syndrome, we can tell that the opposite happens. The relative risk increases with age. And this is because in children with congenital Zika syndrome, the risk decreases as age increases, but not as steeply as it does with children without congenital Zika syndrome. We can see these figures represented in the previous slide. Both papers, both on the mortality of children with the congenital Zika syndrome, as well as the hospital admissions of children with the congenital Zika syndrome, that published. And if you want to learn a little bit more about their methodologies or anything else, you can just read the QR code you see on the screen. But I'd like to bring some of the data that have not yet been published, but they are very important for us to talk about when we refer to children with congenital Zika syndrome. As it was mentioned here more than once, children have a higher risk to display epilepsy and or to develop epilepsy. And these findings by some cohorts drove the World Health Organizations to include children who were exposed to Zika in the prenatal period should be monitored to be checked for epilepsy development. But we realized there were no many studies showing it. We knew that children with the congenital Zika syndrome had a lot of epilepsy, but we didn't have much information on those children who were exposed during prenatal period, but they did not develop they did not have the syndrome reported at birth. So we tried to understand the risk of developing epilepsy in both groups. Children who were exposed and had a syndrome, and children who were exposed but were exposed, they were exposed prenatally but didn't develop congenital Zika syndrome. But this is for you to understand the sizes of these groups in our database. We studied about 10 million children. Among those, 2,700 were characterized as children with congenital Zika syndrome. And we had another group of about 8,300 children who were exposed during a prenatal period to Zika virus, but they didn't display congenital Zika syndrome, or at least it was not reported to our database, and the unexposed children group. we linked the databases from CINASC for live birth, also Zika, for us to understand, about the women who were exposed to congenital Zika syndrome, and also RASP database for us to learn who were the children classified with congenital Zika syndrome, and also information on mortality and hospital admissions. And before showing you the results, I'd like to invite you to pay attention to those women who were exposed, or at least reported as exposed to Zika virus during the prenatal period, and the children didn't develop congenital Zika syndrome. These women have a social economic characteristic that sometimes is even better than those of our comparison group. So if you observe here some other things that I've highlighted, a larger proportion of these mothers had an adequate number of prenatal doctor visits, while children with congenital Zika syndrome, had a fewer number of women with a proper doctor visit, prenatal doctor visits. Here we have mothers with 35 years of age or older. It is somewhat different from what we see in those children who were recorded as congenital Zika syndrome children. Those mothers were also exposed, but their children didn't develop the syndrome. There were also so a much higher percentage of women who declared as white women, different from those mothers of children with congenital Zika syndrome, and the schooling also. The proportion of women with more than 12 years of school education was also higher in this group that was exposed to the Zika virus during the prenatal period, but the children were not reported as with the congenital Zika syndrome. This is just to show you that it is these groups are very different. Those exposed but without the congenital Zika syndrome, or the group that was reported with a congenital Zika syndrome. And then we see here this Kaplan-Meier chart shows children. That outcome here is both the death, which is the dotted line, yellow dotted line, and diagnosis. That we would have the epilepsy diagnostic in this continuous line. And as expected, children with congenital Zika syndrome would have a much higher incidence of epilepsy in their first years of life. And this line, the pink line, these are non-exposed, but you can tell it's very close to those who were exposed to Zika virus prenatally, but they didn't develop syndrome. Here we brought results only for children who developed, the children who were reported as with congenital Zika syndrome. And we see that the risk of epilepsy is very high compared to those who were not exposed. But we also wanted to understand whether there was a difference in risk to children based on children from congenital Zika syndrome from the encephalic perimeter. Those children with a microcephaly and no microcephaly. It seems that the microcephaly children had a somewhat higher risk, but when we adjust for co-founders, we see no risk difference based on the size of school perimeter. And then I wanted to report the characteristics of the children whose mother were previously exposed but didn't develop this congenital Zika syndrome, because it may explain a little bit our results. This is one of the challenges. We are working with secondary data, with administrative data. Maybe those mothers have a much better social and economic condition, and their children are treated for epilepsy in a way that doesn't require hospital admission, be it in an outpatient clinic or in some other way that would not lead to hospitalization. And that's why maybe some of our results and findings is that although we have not found a higher risk in children who were exposed but without the syndrome, it may be explained by the characteristics of those children included in our database. We can discuss this further during the Q&A if you're interested in doing so. But we also kept trying to understand this. I mean, some have already mentioned that these children also present a lot of dysphagia as clinical manifestation of the congenital Zika syndrome. And we wanted to understand whether this dysphagia and other problems that are related to the neurological development of children that would lead to problems in swallowing, in sucking, and also dysphagia, and also for a large rate of hospitalizations and infections, if it would also impact the growth and development of those children. And once again, we linked data, and we linked the data of live birth with the CISVAN follow-up data. The CISVAN is our nourishment or nutritional monitoring database. We performed some measurements such as length, height for age, weight for age, you know, trying to identify those children who were impaired or those who had a proper height and weight that is proper for that particular age. And then we put it together in a table describing children with the congenital Zika syndrome. Here we are only talking about children who were classified as with congenital Zika syndrome, and we see high prevalence of all negative nutritional indicators. We see impairment of height for age, weight for age, and we see also a much lower percentage of a proper height and weight compared to what is expected in the general population. These curves also describe this growth pattern in those children, but we also did some stratification for those who were born small for gestational age, or those who were born with a proper weight for gestational age. And a characteristics they all have this middle então, a gente vê que essas crianças, de fato, têm comprometimento de crescimento. So these children present growth impairment, truly, and this is not solved with age. As they age, they do not reach what is expected for a children that sex, that age. This is another example. This is about boys. We see the same standard, the same pattern. I mean, this one who's small for gestational age, were born with severe microcephaly. This last curve is 0.01. They are still very or much under in terms of height compared to what was expected. Even those who were born with the proper height for the gestational age do not reach the proper height later on. It shows about the same thing: impairment in the children's height And here, I know there is a large number of figures in numbers here, but it was interesting because, I would call your attention to some specific numbers in this slide. This first row, for instance, these are transition models. These models try to understand whether these children who were considered in the first measurement, whether in the next measurement, about 6 months later, whether they would continue that. And most children with the congenital Zika syndrome, those who were born small for gestational age, they have a 57% likelihood of being kept with a severe stunt in the next weight and height measurement. When we observe the group of children without congenital Zika syndrome, we realize that this group, only 15% kept the same nutritional impairment level. And in the same way, if children were here, for instance, 20 to step up to adequate weight, for instance, when they have a congenital Zika syndrome, 25% is the percentage. And in children without congenital Zika syndrome, they have 80% likelihood of stepping from stunt to adequate weight, to the expected weight whenever they are followed up. I mean, children, they keep the nutritional deficit for a long time according to our database. And here we show the same thing, but these are the one. These are also transition models, but this transition model, it checks the time it takes for children with the congenital syndrome and without it to shift state. They were severely compromised, I mean, their nutritional status, and how long it takes in average to get to a proper level. And here, this is in months. A children with congenital Zika syndrome, it takes 12 months to live from a severely stunted to an inadequate status. When this time for children without congenital Zika syndrome is less than 4 months or 3.7 months. Even when they manage to evolve from a poor nutritional state to an adequate nutritional state, it takes much longer than it does to a children without or a child without a syndrome. And then I brought some things for us to discuss and think about when we consider cohorts using administrative databases for congenital Zika syndrome studies. These cohorts are larger in terms of sample size, and we can actually perform stratification and study rare events, which we could not in other cohorts. And because this database includes information both on congenital Zika syndrome as well as on Zika infection of women, we can also understand both issues, both syndrome and only being exposed to the virus. And we have a comparison group, which is also very important in such studies, and it brings some characteristics that we can control as confounders. Of course, there are constraints and challenges. Among those, we have the size, but we do not have the depth. We do not have as much clinical data as primary data cohorts. We don't have much clinical information on a particular child, and there are problems that may lead to misclassification, both a misclassification of exposure, because maybe those children who were classified as with congenital Zika syndrome might have been children with a more severe syndrome. And in the same way, for mothers who were exposed to Zika virus. Maybe these were only those who had access to the laboratory assay or the test. So misclassification is something that we have to keep on discussing when we use administrative database, and the same thing for outcomes, such as in the case of epilepsy, we could only get the outcome which were children hospitalized for epilepsy. We couldn't see those children who had epilepsy but were cared for at outpatient clinics. I mean, this is a problem we also face when we work with administrative database. We also have the possibility of linkage errors, and this is, once we learn how to work with this database, they may provide important knowledge, such as what I showed you during my talk. And then to end, everything we're producing showing the high morbid mortality of children compared to children without congenital Zika syndrome, and we see persistence of it throughout their lives, and it shows the need for well-established care protocols as well as early interventions, and also the importance of medical care so that children will have the least, actually, for them not only to survive, but for them to have a dignified life despite the limitations imposed by the syndrome itself. And then I would like to thank all of you who participated in the Zika platform. They all contributed to everything I mentioned today, particularly Juliana, Luciana, and João, because they performed most of the analysis that I reported to you. Thank you, Annie. Those were very interesting data. We do have some comments on the chat tab, remarks from our listeners, such as
vamos esperar a Elizabeth retornar.
Let us wait for Elizabeth to come back. It seems that she's frozen or disconnect.
Voltou?
Is she back?
Eu acho que não.
I don't think so. But I can kind of read comments and remarks while she's on her way back.
Agora foi a Mari que travou.
Yeah, now it was Mari who got stuck or disconnected.
Gente, então eu vou
Wow, so
ler aqui
I will read some of the remarks written on the chat tab.
Uma sessão de perguntas,
We are now holding a Q&A session both on a YouTube chat as well as on the Zoom chat tab. And then Claudio Enriquez.
O Cláudio Henriques, entrou pelo YouTube.
He's watching us on YouTube. He said that we should remind ourselves that the Zika infection was not mandatory to report until 2013. It was monitored as a sentinel monitoring in 2015, and only later on it was included for mandatory reporting. So probably millions of cases were out of the Brazilian information systems. Alessandra Barros also mentioned her standpoint. She says it's important to consider that morbidities faced by children, severe and disabling, are impact a lot those children with the congenital Zika syndrome. Some of them are frequently going in and out of hospitals. It is also impossible to attend school regularly. She says that her experience has to do with what she's observing in Salvador. That's where she studies. And then now Mari is back, so you can continue. Okay, then let me check this out. Let's see, Professor Suni. I'm back. Professor Elizabeth is back. So yes, I was saying that there was this issue mentioned by Claudio Mirovic on the YouTube channel on in 2014, reporting was not mandatory, so probably we should have a much higher number of children exposed than what the figures tell us. That's true. There's another issue here. It's that because its serological tests are quite poor, and many mothers who were infected asymptomatically. That's why perhaps the number of children exposed is much larger as well. Would you like to say something, Ricardo, Elizabeth, or any on this question raised by Claudia? I may start. Can I? Yes, sure. And then Elizabeth and Annie. Anyway, this is very interesting. There's a whole discussion about when Zika virus was actually introduced. We don't know exactly when it was introduced. Some say it was 2013, some say it was 2014. What we know is that the very first identification of many syndrome cases was 2015. Probably there were cases of congenital Zika syndrome, but we could not diagnose because we weren't even aware that the virus was circulating. But probably we had some cases even during the years of epidemic that were not observed, perhaps because the mothers have been infected, were asymptomatic, and they didn't realize they were infected. Unfortunately, this it's a constraint, both in the we couldn't capture this in the surveillance system. There's no way, and cohorts also were established somewhat later, primary data cohorts that also, and it's difficult to do it retrospectively since the serological tests, especially IgG, more difficult to identify whether the infection was happened before or how early, things like that. Ricardo would like to add something. Yes, two comments actually. One specifically relating the situation in Pernambuco. Mandatory reporting started quite early here. Of course, it didn't capture the early microcephaly epidemic. We first had to realize the epidemic and then to define the specific policies regarding reporting and understanding what is going on. But it started quite early, and it allowed our research group to work together with the State Department of Health. So I believe that in terms of data and reporting, of course, there is always underreporting, but I believe that this underreporting here might have been smaller, starting in 2016. But something else that I'd like to call your attention to is that we had an inquiry here with the population in Recife, and we observed that a large percentage of individuals were IgG positive, so they had been infected by Zika virus. So that's why it is very difficult to talk about the non exposed group. So these large databases, I believe they are extremely important, and we should use the data by comparing data of exposed pregnant women with data of pregnant women, exposed and unexposed. They are important because they are representative of the overall population. They represent what it really happened to the population, but not necessarily. But comparing large databases, children from exposed mothers with a non-exposed mother, it doesn't invalidate this comparison. It's just a matter of, in the interpretation, understanding that we are comparing children of exposed mothers with children of exposed and unexposed mothers, and it may lead us to overestimate some associations. Perfect. We have another question here. I'm not sure you comment when I was out and disconnect, but Tatiana Souza from Bahia, she performs qualitative research, and she's trying to work with the school inclusion, which is a true problem. Most of these children are not attending school. And right after that, we have a comment on this, and it says that, I mean, because these children are frequently being hospitalized and they have family support issues and a series of other issues, most of the times children with microcephaly are not attending school, and those others who were exposed but not having microcephaly, they're also having school problems such as behavior issues at school, learning problems as well. Now they are reaching 8, 10 years of age, problems with math, for instance. Would anybody like to comment on the school inclusion of children with microcephaly? Any mention this website is still with the poor information to work with the database. Ricardo, have you got any information about it? No, I mean, we are working on this data, but this data have not yet been analyzed. We are monitoring the life of those children using the specific tests to check the um, preparedness that the children have to learn math, to learn Portuguese, to learn specific subject matters. And in addition, we are also checking this issue of behavior and cognition, which should certainly interfere in their school performance. We are studying this, but to date, we still don't have this data analyzed, so that we could give an answer to these issues. Yeah, we studied a small group of children and compared to a group of unexposed children. The unexposed group of the ZIP children, ZIP cohort children, we are observing really a developmental delay, really. Julia dos Santos, who is also part of our team, so London School of Hygiene and Tropical Medicine, she talks about this life Zika study. Data have already been collected for analysis to study this specific thing, but they are still under analysis phase. This issue of school education addresses very important topics. These children, they've not only survived the Zika epidemic, but they've also survived the COVID-19 pandemic. So they went through, either infected or not, they went through periods, of very special situations with a social isolation, and all differently from other children. So there are several aspects that must be worked out, both with regards to the biological effects of the infection itself, as well as effects that may be driven by the experience of being socially isolated during the pandemic. Annie, there is a comment on the chat tab about
Então, não apenas para o estudo da
the
Zika, fazer
crossing
linkagem com os
or
dados
linking our data with educational data. That would be a dream. If we have someone from the Ministry of Education listening to us, we would like to negotiate, the access to this database. It could give some answers, not only about children with the congenital Zika syndrome, but other studies that we are progressing at CIDACS. Yes, please, Mauricio. Let me add. Look, working with the secondary data implies that although you have plans on what you want, the bases are not always accessible. Those controlling the educational database in Brazil is the National Institute of Education, INEP. INEP is a very much closed up organization, and they do not offer the possibility of access or linkage or allowing us to access the database, which would definitely allow us to understand that the INEP has data on school progression, on school performance of the students. It would be very useful, but we don't have access to that. Something else that we've recently managed to access the IPC database, and it will certainly offer us elements for us to check the effects of protection policies of those children and what were the benefits. It might be possible eventually in the future to assess it. But regarding the educational process, we expected that one day INEP will allow us to link INEP's data with the data of cohorts studying Zika at CIDACS. Alessandra Barros also commented that Dr. Marcia Platt in Rio de Janeiro and the Bahia group with Regiane Barbosa, Sheila in Salvador, and even Alessandra herself are working on school inclusion also, and we expect to have results very shortly. Let me ask a question to Mauricio and Emni. How will it be in addition to the overall data protection data? Are you finding it difficult to access large databases? Is that what I heard? I mean, it's not the data protection legislation. The Brazilian data protection legislation is quite generous. It understands that the nationwide database belongs to the Brazilian society and may be used to the benefit of society. The law talks about research many times. It devotes a whole chapter of the data protection legislation. It's only legislation that says public health research is a priority and we can use it, but our managers, perhaps they didn't understand it, they don't want to understand, or they just don't care, and they keep it difficult for us to access. It's not simple to access. We have had access to many nationwide databases, but these are always very long negotiation processes, despite the security that we have at CIDACS. CIDACS has a wonderful data security system, but it doesn't matter. Sometimes they just don't allow. So we don't work just with the Zika. We work in many other research lines. We're managing to do things. We could be better, could be more flexible, could be more inclusive. Like we said, for instance, education, we find it difficult to access that database. All right. But it's not it's not about the data protection. The digital data protection legislation is not to blame because our legislation for data protection is quite interesting. It actually invites the communities of researchers in the society to use the nationwide database to the benefit of the society. And this is something that lawyers or those who interpret the legislation sometimes don't see it this way, but I see it is an extremely generous legislation. It's good to have your insights because now we can use it as an excuse to have access to data. Elisa Williamson asks Ricardo to clarify the finding on the lack of significant relationship between race, color, schooling, region, and incidence of Zika syndrome.
Pode falar, Ricardo.
Yes, please, Ricardo, go ahead.
Colocar a questão, porque eu li o
No,
comentário.
no, I read her comment, yeah.
Então, eu acho que ela tem toda a razão.
She is absolutely right. We agree. So I was actually referring to the risk. I mean, once the pregnant woman is infected, the risk of a microcephaly or other symptoms are not yet related with any other factor, regardless of ethnicity, regardless of social economic settings, regardless of place of birth. But this is different from the risk of infection to the general population. So we do have some studies showing a clear association between the Zika virus infection in the overall population and their social economic conditions. That's why microcephaly cases are observed, particularly in low income populations, because that's where the poverty is. This is where the mosquitoes are, really. So the association with poverty and deprivation is quite clear regarding the transmission of the disease of an infection. The risk, once identified, the risk of congenital manifestations don't change based on social and economic conditions. A last question, because we are reaching the very end of our webinar. It's to Elizabeth Brickley.
Vamos acessar aí a tradução.
Betania asks you, Elizabeth, about the prospects of studies with mixed methods at Life Zika.
Oh, thank you, Betania, and thank you everyone for the good questions. I think really this is an opportunity that we should capitalize on and that we should take full advantage of. Are really to conduct these mixed method studies to understand the challenges more fully. Even just within the cohort studies, I know if we are to look at the secondary data and to look at some of the questions around parental education, we see some differences from what we see in the clinical cohort. And so understanding what lies behind those differences is really important for moving forward. But I think it's particularly important too if we can have a closer relationship between our quantitative researchers together with our qualitative researchers to, we can take a question like the question around school inclusion. And I think quantitatively, it's really important that we document the experiences. So how many children are missing school? How many days are they missing of those who attend? But that only tells us part of the story. And we really need to work together with our social sciences, our qualitative, our educational partners to understand, well, what are the reasons behind it? And how can we go back to the root cause of those differences? We need to understand, what does it mean for the full life of the family that the child is not in school? What does it mean for the caregiver and the time that they're home taking care of the child? And so I think I really hope that this is an area that we can continue to develop together. And it's something that I think there are some very key important topics that we can begin to work on together. And I'm really grateful for the partnership that will allow us to do so. But I hope to see a lot more mixed method studies in the future.
Ok, obrigada. Gostaria de agradecer os participantes desse
Thank
webinar.
you very much. I'd like to thank all participants in this webinar, Elizabeth Brickley, Ricardo Ximenes, Annie Cruz, and I will give the floor back to Mariana Pita to close the seminar. Thank you, everyone. Thank you, Professor Elizabeth Moreira. I would like to thank you all again. Thank everyone who's attended this webinar since yesterday, especially all invited guest speakers who accepted the invitation and delivered their wonderful talk since yesterday. This was a great opportunity to gather individuals who are leading health care management, the society, researchers leading studies on congenital Zika studies in Brazil and abroad. I'd like to especially thank Professor Maria da Glória Teixeira, coordinated together with Professor Maurício Barreto of the Zika Platform. She also supported us in putting together this webinar. And finally, I would like to thank everyone who made efforts so that this event could take place. The whole group of the Zika platform, and I will not mention every name, but I would like to particularly thank Professor Maria Gloria Teixeira, Betânia Almeida, and the Center of Communications at CIDACS. We have held wonderful discussions, and I'm sure we are going to have further opportunities. It will continue. Next month, for instance, we will have an opportunity to keep on discussing this in Recife, Brazil. I'm sure that many of you will attend Abrascos's Congress and the Congress of Tropical Medicine, and it gives us opportunity to keep on discussing. We expected Zika platforms and all groups involved in the life Zika studies will keep on producing quality, updated knowledge, thus collaborating to the appropriation of consistent, up-to-date scientific knowledge to understand this problem, which is quite complex. We have an opportunity to discuss just one part of the scientific agenda around the Zika virus and congenital Zika syndrome. But of course, we cannot, in a couple of hours, to approach all of the scientific agenda. Many questions were asked on education. We can have a whole seminar just about the educational issue, right? But we hope we can continue studying comprehensively and deeply, collaborating in the management and practice of healthcare professionals, develop public policies for children and families affected by Zika epidemic. And to end, I will give the floor to Professor Barreto for the closure of this wonderful event. Thank you very much. Professor, you're muted. Yeah, we always forget to unmute the microphone, but never mind. I'd like to start by thanking both Mariana and Betânia, because those were the individuals who inspired us hold this webinar. We had great talks yesterday and today, and we could tell from the talks how important it was, reminding ourselves of what happened and keeping alive the importance of keeping studying this epidemic, not only as a subject to scientific exploration, but an ethical and moral issue for us researchers to understand what actually happened and raise the awareness of the Brazilian society on this particular issue. I believe we play a fundamental role, not only in making strict science, but also help keeping alive this issue of Zika virus. We had wonderful discussions yesterday. If you were not here, I will let you know that we have representatives of an American health organization. We also had Dr. Agnew, who used to be the executive secretary of the Department of Health, who coordinated it directly. So we had the opportunity to better understand the activities implemented by the Ministry of Health back then by mobilizing the society and the governors of different states around important activities to try to solve, to mitigate, or to understand really the issue. How different it was from what happened later on, with the pandemic, where the ministry will play a very different role in approaching the problem. And we also saw how the Brazilian scientific community reacted. And this is very important, today's today's talks show us how, a scientific group in the northeastern Brazil, where we had the epicenter of the epidemic, and all the groups in Brazil tried to get together and understand the problem, and they are producing important papers, to demonstrate the association of a congenital Zika syndrome to the actual Zika virus infection. It was a very important event. Is part of our commitment. And once again, I thank Betania and Mariana. We inside CIDACS have this natural appeal to work with the things that are important and relevant to the health of the Brazilian society. That's what we are after. We cannot always manage to, but that's our aim. And Zika was something that mobilized us all from the very beginning. To give you an idea, the Zika platform was created even before CIDACS was founded. We still, we didn't have everything organized, but the Ministry of Health invited us to contribute to everything related to Zika. And with this, we had the creation of what we called Plataforma Zika, and that was something we did with the support of the Ministry of Health, as they supported other groups in Brazil, so that we could gather efforts to understand the Zika issue. And the platform, at its initial phase, it started in 2018. We had a health exhibit at CIDACS. Wagner was one of the main organizers of this exhibit, and we have recordings, we have images of this exhibit, and our colleagues who are studying the components about how society reacted, there is so much material from this health exhibit, material that has not yet been explored in this exhibit. It recorded a wider range of community experience of different movements in Brazil, a movement of reaction and organization of the civil society when we had the outbreak of Zika, in reaction to the Zika outbreak. And it will start growing as it is still today. The movement of the Zika families is a very solid movement. It's a very important movement to ensure the continuity of care and policies. And it's been very important, such as the approval by the government of the lifelong support to children affected by Zika virus infection. So we had two wonderful and important days, and I like to tell you that our idea was to keep this phenomena alive and to let you know that we researchers are committed with the health of the Brazilian society, as well as others who were invited and accepted the invitation. We hope there will be further initiatives from other groups, and other activities after these 10 years of epidemic, and then just our contribution to the discussion. Yesterday, for instance, we had a representative of the Zika mothers. It was quite touchy to listen to her. She is a leader in this area, but it was more prone to researchers and to discuss research questions. And the idea was to have representatives of important groups in national research, and I thank all the speakers today, Dr. Brickley, Professor Ricardo, Professor Elizabeth, and Annie, who represented efforts made at CIDACS. And to tell you that knowledge is diverse. There's a lot of diversity in knowledge, but we have a huge potential for networking, for contributing, for setting up processes that can actually leverage knowledge. And that's what we are discussing here. It's precisely all about the 100 million cohorts, and or the both cohorts is not to solve all problems in the world, but just to offer elements that demand knowledge that is necessary for us to understand such complex problems as Zika virus. The Life Zika project, led by Elizabeth, together with Ricardo and others, Elizabeth Moreira as well, it represents this spirit of union, and the spirit of going after understand a complex issue and how science can contribute to this. I'd like from the bottom of my heart to thank you on behalf of CIDACS, not only organizers, Mariana, Betania, Victoria, Mariana, Sebastian, and others as well, and speakers, and all participants yesterday and today, and to tell you that, of course, the issue is still on the agenda. We have had an epidemic of a very severe disease that left effects that are observed even today and will still be observed for a long time to come. But to understand that this epidemic was extremely important, not only in terms of what those affected require, but also as researchers, we should enable public discussions around it and think about how to deal with the future epidemics or future effects of this epidemic, or perhaps be able to mitigate the effects of future epidemics. Liz showed today that Zika is still circulating, and we might eventually have another epidemic, as we can have epidemics of other diseases, such as we have had of COVID-19 and others. But studying historical events is an important element for us researchers, and I believe we can only understand this phenomenon if we really get together, we network together, we discuss knowledge, and we truly understand the knowledge as complementary things, as well as the several strategies for knowledge production complete one another. Thank you so much. And Mariana, you can finally close. And of course, if anyone wants to, say their last remarks, be my guest.
Reforço, né, as palavras do professor
Yeah,
Maurício.
I echo the words, Professor Mauricio, and if anyone would like to use a minute for last remarks, I will only say goodbye and wish you all a wonderful Friday and a great weekend. And now we close our event by thanking everyone who remained here until now, especially speakers and invited guests. Thank you very much.
Tchau, então. Tchau, todo mundo.
Tchau,
Obrigado
tchau.
aí.
Ciao. Record